Well, we'll turn the microphone over to Dr. Valji. Thanks so much, you guys. Happy learning.
Thank you. And thank you, Dr. Valji.
Thank you. Can you all hear me?
We can.
Well,
Yep.
can? Good. Okay. Let me. Can you see that?
Yep.
You can see the PowerPoint. Okay. Well, thank you. So I'm going to talk today about patient care and evaluation in interventional radiology. And I understand from tests that the majority of you are somewhat more junior residents. So I think there may be more of you than usual that have not had any or spent much time in interventional. So this talk is really to help you work on that service, but it also is useful to any radiologist who goes on to practice and does any kind of procedures, which is most of you, even if you're not doing strict high-level IR. And although some of my colleagues might not agree with this, I think that the material I talk about here is by far the most important material that you need to know in interventional radiology. I really believe that how well we decide which patients benefit from an IR procedure, how we evaluate them and prepare them for it, and how we take care of them afterward is at least as important as those complicated procedures we do. It just, after decades of doing this, it is so important. And so having this foundation of how we do this is really critical. So that's why I want to spend a whole hour or so of these precious lectures talking about this. What we're essentially going to do is we're going to talk about what do we do when a person calls on the phone into the IR lab and says, I've got this patient with blah, blah, blah. What do you do? And then once you've decided that, in fact, we should do a procedure, how do you evaluate that patient? How do you prepare them for a procedure you have planned? How do we take care of them safely and properly in the procedure? And then what do we do afterwards? This is the most important slide. And as I get older and older, those of you that have been on IR have heard me harangue the other, some of the other folk, particularly residents and fellows, when they talk about procedures and go into details about what we're going to do and what catheters and stuff, is that the first thing you need to do is stand back and be a doctor and decide what is the patient's story. And given that story, what's best for the patient? So no one should call down to IR and say, I want a TIPS procedure or I want an IVC filter put in. Those are techniques, those are things technicians do. What you want to get from a referring doc on the phone or in whatever form is a story of a patient. And you're going to listen to that story, you're going to review the record, and your first job is to decide, is an IR procedure indicated? It's not up to the referring doctor. You decide, any more than no internal medicine doc could tell a surgeon, I want you to do a CABG. That will be unheard of. IR should work the same way. We're doctors, not technicians. So you need to decide, is a procedure indicated? If it's not, why not? Not just because you don't want to do it. There's got to be a reason. And is a procedure you imagine in line with referring provider's expectations? You want to make sure that what you're planning on doing works with what they want or expect. And if not, that you want to align those two. And you need to be able to defend your recommendations. When you say, I don't want to do a thoracentesis, or I don't want to do a TIPS, or I don't want to do an abscess drainage. Why? You should be able to, based on literature experience, say this is the reason. And if not IR, then you should be able to propose something. Maybe it's better just to watch the patient. Maybe conservative medical treatment is better. Maybe rather than doing a drainage catheter, maybe simply an aspiration is better. Take out fluid from the pleural space, don't put a catheter in. Or maybe an operation is better. Sometimes IR needs to say, we're not the best folks to help this patient. Once you've done all that and made a decision, if you want to ideally place a note in the record with the rationale for your decision, just like a surgical consult, you should do that. And obviously for routine things, it's hard to have time to do that. But otherwise, you want to put a note outlining what you just described. So this is really where the most important art of IR is deciding, should we do it and what should we do? And that decision is up to you. Then once you decide to do it, this is a checklist. This is kind of a compilation of what residents over the years have kind of listed of the things that a lot of them have this on on their iPhone, wherever. What do I need to ask? Well, I got the person on the phone. So you want to know how to this is the kind of the cheat sheet. How do I contact you once I figure out what I want to do if there's a problem? What's the timing? Is it elective, urgent, emergent, and why? Because everyone will call and say, I need it now. Well, that's not true with most procedures. So you need to really decide, what is the timing? So how do I need to fit this into our schedule? What's the NPO status? Because that will affect sedation. What kind of sedation or anesthesia will be needed? So you need to kind of go through the checklist from the record, and we'll talk about this in a moment, about whether or not we can give sedation or we need anesthesia. And that particularly, you want to be looking at the BMI, history of chronic narcotic use, and history of sleep apnea. Who gives consent? If it's the patient, fine. If the patient's unable to, for whatever reason, you got to figure who that is, and how you're going to contact that patient. Does the patient family know about the plan? You don't want to go up and start talking about a complicated procedure when they've never even heard from their primary doctor that something is planned or being considered. Allergy history, relevant medications in the last dose in terms of anticoagulants and antibiotics, recent labs, especially platelet count and INR, and then others depending on the procedure you're doing. And then finally, recent imaging. And the last element, you need to review it yourself. You don't want to look at the report. Remember, we're radiologists, we're not vascular surgeons. We need to look at it and decide, does the imaging support what I want to do, and what kind of problems could I get into in doing the procedure? And that's where going over the studies is important. So once you've done all that, you get off the phone, the first thing you usually need to do to get the schedule is figure out how you're going to sedate the patient, because most patients need sedation for our procedures. So throughout this talk, I've got a couple of questions to kind of keep you guys engaged. So here's one. Which of the following conditions is not true for a patient under moderate sedation? Adequate spontaneous ventilation, cardiovascular function remains unimpaired, airway maintained without intervention, purposeful response calls for repeated or painful stimulation. So if you're giving moderate sedation, which of these is not an appropriate condition? I don't know if you have your mutes on, that's okay. So D, purposeful response requires painful stimulation. That's deep, not moderate sedation. So these are the options for all IR procedures. We can just give local anesthetic, and sometimes that's enough. We can do mild sedation, which means a patient responds normally to verbal commands and ventilation and cardiovascular function unaffected. Most frequently, we do what's now called moderate, used to be called conscious sedation, where the patient is drowsy but responds purposely to verbal commands or light touch, but maintains an airway and ventilation. The more deeper levels, deep sedation and general anesthesia, which I think are kind of obvious what they are, those we cannot deliver in IR. It is not allowed or safe for a radiology nurse and doctor, IR doctor, to provide that. So if we think that that's necessary, we need the anesthesia folks involved. So if we can do local anesthetic or minimal sedation, that makes everything easier in terms of logistics. So that's the thing to do if you can do it safely and the patient will be comfortable. So for local anesthetic, that's kind of obvious. Minimal sedation, the rules are here at UW, you can only use one agent. Patient cannot be too young or too old. You got to still follow vital signs. And the agents allowed are lorazepam, diazepam, fentanyl, up to 50 mics for chlorohydrate. That's it. So you've got to decide, if this is enough, if those doses and types of drugs are enough, then I can just do minimal sedation. Now, the real distinction is, can we do moderate sedation with a radiology nurse? And if not, do we have to do moderate or deeper sedation by anesthesia? Because this changes whether or not we need to get another service involved. And you want this to be the first thing you do, because you want to get these things planned. And this is the biggest obstacle to getting procedures done. So we got to figure out, are we above this line or below that line? How do we do that? Well, number one, we have to give everyone an ASA, American Society of Anesthesiology, classification. Now, these classifications are very broad, and the reality is that we largely can only do patients in category 1 or 2, sometimes category 3. So kind of by default, if we're going to do it, it can't be category 4 or 5. But this gives you kind of a guideline of what anesthesiologists think we should be using. So here's an example. Which of the following conditions precludes, can we not deliver moderate sedation by the radiology nurses? BMI of 40, pulmonary pressure of 25, chronic kidney disease, patient on hemodialysis, 20 weeks pregnant, or an indwelling pacemaker. Which of those can radiology nurses not be able to provide sedation? Answer is 20 weeks pregnancy. Now, you're not going to remember all these things. This is the sheet, and you'll find these both online on our website and posted all over the IR rooms at all the hospitals. These are the selection guidelines for moderate sedation as dictated by anesthesia. These are the absolute contraindications. If a patient has these, radiology may not sedate the patient. It must be anesthesia. So the big ones here are previous bad reaction, morbid obesity, BMI greater than 45, history of difficult ventilation, EF less than 30%, pulmonary hypertension, systolic PA greater than 40, and then some others. These are mandatory consults. So these are patients whom, if you've got to get anesthesia to see or bless the patient, and if they don't, they have to do the procedure. But if they do bless the patient, say, yes, your nurses can do this safely, then we can proceed. And the biggest ones are sleep apnea, non-compliant with CPAP. So if you have sleep apnea to bring your CPAP machine, we're cool to do it. If you don't, you might need anesthesia. BMI 40 to 45, borderline, and then advanced lung disease and homo-2. So if the BMI is 40 or 45, we do what's called the stop-bang score. And again, this is basically a survey that's done for patients who might have sleep apnea. And you basically answer all these questions. And if your score is 4 or greater, then we need to get anesthesia involved. So the bottom line is you want to go through that checklist with everyone. And after a while, you'll kind of get to know most of the criteria. But you need to do that or you're going to potentially delay a procedure. Logistically, we've got 2 teams that work in radiology, basically working hours, weekdays. We do share them with DR and body procedures, so we don't have them to ourselves. The team is a CRNA or in resident or an anesthesia attendant who kind of floats around. Our schedules can fill the blocks. So you can work with them. Also, you can work with Anthony Vega, who's kind of our coordinator for some of that. For urgent needs, you can contact the anesthesia resident of the day or our nurse coordinator. And just to note that these anesthesia teams attend our morning conference, so we talk about all anesthesia cases with them at the beginning of the day. So what's the next thing you're going to do? You're going to need to get consent from the patient. So basically, it's the obligation of any doctor performing any procedure to explain anything you're going to do to a patient. What are you going to do? Are there any alternatives to doing what we're going to do? What's the benefit and risks? And then what do they expect in the long term? And these are the elements you need to talk to. Be aware that the term informed consent is a medical and a legal term. In this state, the courts believe that informed consent should follow a reasonable patient standard, meaning you need to explain to the patient you need to talk about particularly the risks of the procedure as a reasonable patient would want. Meaning you don't need, if you're talking about putting in a central line or a port, you don't need to talk about death because the risk of that is so remote. You don't need to speak as if this is a patient who wants to know everything absolutely possible, just what a reasonable patient would want. And how you do this becomes a personal thing. There are doctors that will say death for every kind of procedure. I don't think that that's the way to go, but you could do that. You just need to have a consistent way of doing it. But you certainly want to talk about those risks that are either relatively common for that procedure or profound risks. An example might be you do a bronchial artery embolization. We always consent people for paraplegia. The risk of that is probably 1 in 1,000, but the consequence of it is so grave that you want to always tell patients about it. So this is how you don't do informed consent. You don't do it in the room, having not talked to the patient. That's coercion. You can't use a family member as an interpreter because you don't know what they're telling the patient. You don't want to do it if you don't know anything about the procedure. Don't let senior IR resident or attending say, go get consent on this patient for a TIPS when you've never even seen it or know nothing about it. That's wrong. And you never leave it to the referring team. It's not their job, it's our job. We're doing the procedure. So how should you do it? Hold on. As far away in time and space as possible. So as soon as you can, ideally the day before or in clinic, do it in a quiet, private space and sit down. This is just a general rule that for any time you interact with a patient, and I try to do this, whether it's in clinic, whether even in the bays when I'm getting consent, grab a chair and sit down, because what that tells a patient is, I am here to listen to you. I'm not going anywhere. I care about what you're going to say. Just that very act of sitting down, even if it's for 5 minutes. Use a hospital interpreter if needed. That's required. You can't use the family. Include family members if possible in the consent. Anybody that's around that is involved with that patient should hear about what you're doing. And if you can show images, that's really, really appreciated. So here's a situation. A patient about to go on procedure speaks only Korean. Which of the following individuals may serve as an interpreter? Patient's daughter is fluent in Korean, and IR technologist is a native of South Korean, fluent in language. Hospital interpreter by phone, conference call, B and C are all of the above. Answer is hospital interpreter by phone, conference call, because you can do it by phone or by Zoom or some other kind of video conferencing. The reality is occasionally we will use an IR technologist. That's not kosher, but we can occasionally do that. So a couple of points about informed consent. Number one is in an emergent procedure. Someone comes to the trauma unit and is dying from pelvic bleeding. You don't need to get consent. This double docking is not a real thing. I mean, you can do it, but it's not necessary. In this state, you have what is called implied or presumed consent, which means you have the right to do anything on a patient where you believe that the patient, there's an immediate risk of life or limb, if in your clinical judgment needs to be done. And if you're worried about it, write a note to that effect, but that's all you need. You don't need to double dock. Second point, if you or a member of the referring team, including nursing, doesn't think the patient's condition allows them to give consent, stop. You don't want to go up to the floor and get consent on some patient who seems a little bit drowsy or out of it, who you think probably can give consent, and have the nurse say, I don't think that person can give consent. If something happens, you're in real trouble. So you need to consider anyone who knows that patient who is concerned about that, and maybe get consent from the legal representative, who must be able to understand you without intermediary bias. So you need a translator if so. Telephone consents are fine as long as you get a witness and have that witness sign a consent form. And of course, obviously document everything you encounter. That old saw, if you don't record in the EMR, it didn't happen. So what do you say? Well, here's how I do it. Still, it's basically 3 points plus 1 point occasionally. Number one, adverse events at the access site. So it's like, where am I gonna enter the skin? What bad thing can happen where I enter the skin? If it's like at the artery or vein, well, it could be infection or bleeding or pseudoaneurysm or dissection or thrombosis, and you want to have some idea of numbers. If it's not in an artery or vein, then it's probably just going to be infection. Then I think about, well, what am I doing? I'm going to go from the skin, and where am I headed? What's my goal, my target? And what's in between? Nerves, vessels, bowel, lung, whatever. You kind of think anatomically. You don't need to remember what to do for each procedure. Just think about the anatomy and think, well, I could hit the pleura and that could cause a pleural effusion or empyema, or I could hit the bowel and that could cause perforation and some problem. So think about all the bad things that can happen en route to where you're going and talk about that. Number three, talk about adverse events from medications, including from sedation or anesthesia, contrast-related allergy or nephropathy, and if you can use anticoagulants, the risk of bleeding. And then number four, the cases that are really long, like a venous recan with chick or chin, or a TIPS, or a complex AVM case, those you want to talk about radiation injury. Because we have had patients who've got severe radiation injuries, have not been consented for it, and there have been serious problems because of that. So don't forget that. So with regard to radiation, it's a rough estimate. What major complication rate for an IR procedure should be quoted to patient, not radiation, but for the procedure should be quoted to patient and families? What number would you use? What I use is 1 to 2%. That's just a good rule of thumb. That's likely that something really bad is going to happen. Okay. These are some of the numbers. And again, I'm not going to go over them. If Tess or if any of you want me to make a PDF of this, I'm happy to send this talk to you so you have it as a reference. But these are some of the rates that are kind of useful to know. But I think a 1 or 2% rate of major complications is good, as I mentioned. Let's see. Overall company 1 to 2%. And then I usually quote a frequency of minor complications of 5 to 10%, with the frequency going up if you have risk factors, obesity, advanced age, what have you. So what's the next step? So we've figured out sedation, we've got consent on the patient. Now we're going to have to figure out pre-procedure issues. So there are two things you got to do: lab screening, and do we need to give any drugs beforehand? And the drugs might be for contrast reaction, for issues of bleeding or infection. So lab testing, we do it. We don't need to do it because there have been scores of studies that have looked at indiscrete kind of, just generalized all-comer screening of lab tests before invasive procedures. They are useless, but hospitals still require it. So we end up doing it. One thing I would mention is that tests performed within 1 month of a procedure are valid if there's no change in clinical condition or new risk factors. So if someone had the INR and platelets checked 2 weeks ago, unless there's a reason those two have changed, you don't have to check them again. It's just wasted money. We're just adding to the horrible healthcare economic system. This you should know. What are the risk factors for bleeding for IR procedures? This you almost should commit to memory if you're going to do IR. So low platelet count, presence of any anticoagulant medications other than aspirin, liver disease, history of bleeding, diathesis, malignant hypertension, hematologic malignancy, splenomegaly, DIC, and then malnutrition or selected chemotherapeutic agents. But the top 3 or 4 are the most common ones. So what do we do about that? Because we need to determine, is the patient at risk for it, and should that prevent us from doing the procedure or giving medication to prevent it? So the way SIR works, it has Society of Interventional Radiology, they have divided the main IR procedures into 3 categories: low risk, medium risk, and high risk, to determine what you need to check and what you need to do. So low risk are things like putting in an IVC filter, tunneled catheter removal, non-tunneled CVCs, thoras and paras, and so on. Medium risk procedures are most of the things we do. So just think everything else except the high risk. So that's the best way. Know the low, know the high risk, and then you know the middle. So high risk are TIPS, transjugular kidney biopsies, which we rarely do, percutaneous kidney biopsies, initial placement of a biliary tube or a nephrostomy tube, and RFA. So these are the 6 types of procedures that you really want to be careful about checking for bleeding risk. So we screen with INR and the platelet count and the PTT. And this is what we need to check, although we end up checking all of them on most people, even though it really is not necessary. For the high risk, in addition, you want to check the hematocrits. You want to know where you're starting, because if they do bleed, if their crit is 18, maybe you need to have blood ready, or maybe they need to be given blood beforehand. So this is the one group in which checking the hematocrit, which often is checked with the platelet count, but actually looking at it and acting on it is important. So patient with a normal INR, what's the platelet count threshold for placing a tunneled dialysis catheter, one of our most common procedures? The answer is 25K. Now, 50,000 platelets is the standard threshold for most IR procedures, but fortunately not for tunneled, not ports, but tunneled central venous catheters. There's good data to show that the risk of bleeding, if you let the platelet count get as low as 25, as long as your INR is normal, is absolutely acceptable. So, and that's great because we do so many of these procedures. So 25. These are the thresholds. Typically INR and IR, we want it to be less than 1.6 to 1.8. We want the platelet count to be greater than 50,000. For tunneled central venous catheters, the INR can actually be less than 2. And if we're doing just a venous procedure, we can act, particularly from the jugular vein, it can be even less than 3. And then if there's an abnormation of coagulation, then we want to correct that. INR typically withhold warfarin if they're on it. If it's not a warfarin effect, then you want to give FFP, although this doesn't work quite as well with patients with liver disease. In rare cases, if the FFP is, if the INR is markedly elevated, the patient's exsanguinating, you can give vitamin K. It works, takes a little time to work, but unfortunately, once you've given it, you can't anticoagulate the patient with warfarin again for a while. So that's problematic. And then there's always prothrombin complex concentrate, which will act very quickly to correct that. Obviously, for platelets, we're going to want to give a transfusion. If we think the platelets are just dysfunctional with a renal failure, then DDAVP can help make them a little bit more functional. So question, how long should clopidogrel, Plavix, be held prior to performing a percutaneous liver biopsy? The answer is at least 5 days. Because the half-life, Plavix is basically an irreversible antiplatelet drug. So, and the half-life of platelets is 5 to 9 days. So really the only way to minimize that risk and reduce and eliminate the coagulopathy or minimize it is to go through basically the half-life, or the short half-life of platelets. So we have platelets present that are not affected by the Plavix. So 5 days, ideally. So, and then what about management? So basically, depending on you stratify the procedure you're doing, is it low, moderate, or high? And then you decide what you're going to do with the drugs they might be on. And again, I'm not going to go over this. I'll send this to you and you can have it. But so if the patient's on any one of these, let's say a DOAC, like rivaroxaban, because this is one of the more common ones, for a low to moderate risk procedure, we're going to wait 24 to 48 hours. That's variable depending on the attending and the procedure. For high risk procedures, sorry about my screen, it's just not responding well. High risk procedures, you're going to hold the DOACs for 48 hours. You're going to hold Plavix for 5 to 7 days. You're going to hold warfarin 3 to 5 days. Anyway, so this is the action you need to do. And obviously this will impact when you're going to schedule the case. So that's why you need to do this in advance so that you can not delay a procedure or delay it as needed. There are charts in the various IR lab workrooms with the thresholds for all the various procedures we do. So you don't have to really memorize them, although you can see there's some general guidelines here. Moving now to contrast. Contrast material pretreatment is never warranted with a solitary risk factor of, and this is basically, we have our own recommendations in radiology at UW. So allergy greater than 5 medications, symptomatic asthma, prior allergic reaction to contrast requiring treatment more aggressive than Benadryl, prior contrast reaction with 14 hives. I don't know who counts these, but mild cutaneous edema and sneezing with prior administration of the same agent. And the answer is number 5, number E, letter E. So contrast reactions. This is something you obviously are learning from CT, from body imaging rotations and so on, as much as from us. So I won't spend a lot of time. Obviously, you know about the various categories of risk categories. And again, these are the category. This schema has been set up by UW contrast reaction group, and that does vary has changed over the years. So I would check for the most recent set of guidelines, but we do have a pretty standard way of categorizing them, classifying them. And based on that, we decide if we want to do pre-treatment. And I think you probably know the regimens. These are the 2 most common ones, Medrol or prednisone, 13/7 and 1 hour before the contrast. If a patient comes in with a severe contrast allergy, and you've got to give contrast because they're dying from a pelvic bleed, you can do that. Although there is no good scientific evidence, the ACR still does recommend and endorse giving IV steroids as soon before as you can possibly do that. So that is something that you can do in an emergency. Risk factor for contrast-induced nephropathy, I don't want to spend much time on that. I think that's something you all know or will know. Pre-existing renal function, age and diabetes are probably the most common. how do we prevent it? Again, there's more and more debate over the years recently about how real contrast nephropathy even is. But certainly in any event, you want to minimize the iodine contrast dose, of course, now because we're low on those agents. But you just, as a general rule, want to always do that. Use the minimum dose of any drug we give a patient. If you're concerned about it, then the only really well-proven and effective way to prevent that, if you believe it, is with IV saline hydration. And there are various protocols that you can use. As an alternative, in angio, we can occasionally use carbon dioxide. Okay, next, antibiotics. So repairing the patient. The surgery will tell you that we should give prophylactic antibiotics when infected tissue or colonized mucosal surfaces may be breached. That's the concept in surgery. We would also add, before we ablate something, before we destroy tumor is going to, or particularly that's become necrotic. And if we're going to give antibiotics, surgical practice dictates that they be administered 20 minutes before. You don't give the drug after you've done the procedure. You got to get some of the drug in, ideally all of it. And sometimes we continue the drugs after the procedure, depending on what's happened. Now, why do we give antibiotics? Well, the main reason we give them is it's tradition, because we have followed what they've done in surgery for years, decades, generations. The other reason is fear, which is that even without, and the reality is there are almost no trials that have proven any benefit to the antibiotics we give, but we do it because we're kind of afraid something's going to happen, which is unfortunate. We do a lot of things in medicine, but that's just reality. So, as I said, there's almost no data. Here's the data for prophylactic antibiotics for tundral central venous catheters and ports. There's no proof. And in fact, 15 years ago, we used it all the time. Now we do not, fortunately. So we don't use prophylactic antibiotics for vascular access, except in rare situations. This is actually one of the only studies in the whole literature. It's done by our great Chris Ingram and Guy and Emily Albrecht a number of years ago. This is actually a randomized trial comparing placebo to IV antibiotics in patients receiving percutaneous gastrostomy, which is such a simple question that's so important. And their group did this study, which basically showed there is barely a benefit to it. Now, whether you want to give it or not is another story, but at least there's evidence here of some benefit to giving it in preventing stomal site infections. So other than that, all the antibiotics that we use are given based on just tradition. So routine prophylactic antibiotics are not indicated for which following procedures. So let's see if you know this. So we don't give them for a nephrostomy in a patient with prostate cancer, or how about cholangiography in a patient with hepatocogeginostomy, maybe after a transplant and a drainage catheter in place. TIPS procedure for variceal bleeding, chest port in a patient with breast cancer, uterine arterial embolization for fibroids. So which of these 5 procedures would we not give antibiotics? I think we alluded to that a couple of slides back. The answer, of course, is chest port placement. So again, there are lists in the IR labs of this. You don't have to memorize them, but you will get to know them over time. So these are the recommendations for prophylactic antibiotics. And over the years, we have these revised every year by our infectious disease gurus. So they're kind of in line with what we think should be done. So yes, give them for virgin biliary procedures, so a new percutaneous biopsy, and for transplant cholangiograms, because they tend to be infected more than others. Most GU procedures, so all percutaneous nephrostomies, G-tube placement based on Chris Ingram's study, tunnel line supports only if they are severely neutropenic, so an absolute neutrophil count less than 500. Then we give antibiotics. Drainage of suspected abscesses, that's questionable. You think, well, they have an abscess, you probably should be on them, but it's not clear you need to do that, although they're often on it. Again, if we're going to cause ischemia or infarction, we do it. We do it with TIPS because we might enter the biliary system. We do it when we might place a device that's got fabric in it that's a little more prone to infection. And we do it when we think we might have caused infection because the case went on for a while or there was a breach of sterility. Maybe is for thrombolysis and ablation of solid tumors. No are for all the others. no antibiotics. And again, this list, you're never going to memorize it. It changes from one year to the next, but we have very, very good guidelines for exactly what to use. So you don't have to make it up. You just look at what am I doing and what's being recommended. Now, so you're trying to choose an antibiotic. And of course you look and it's like, oh, patient's got a penicillin allergy and I want to give answer. It's like, oh God, now what do I do? Well, fortunately, there is actually an algorithm set up here by infectious disease, infection control about what to do about this. And again, this is also in the labs. And if not, you should get it, get it if I give this as a PDF. This is what you do in terms of determining, is that risk factor that's documented in the chart really serious enough for me to not give Ansep in a patient, let's say with the penicillin allergy. And again, I won't go through this, but it basically involves asking the patient directly or their family, what's the real story behind this allergy that's listed? And depending on how they respond, if it's low risk, then it's okay per ID to use a cephalosporin, even if there's a so-called penicillin allergy. On the other hand, if they had skin peeling or sloughing or some severe reaction, then you're absolutely not going to do that. And then you're going to use something that is for which they most certainly will not likely react. So again, just you follow this algorithm and that will tell you what you need to do. Site marking. I will just briefly tell you that the Joint Commission, although I'd like to say this always is done in IR and body procedures, but I'm not sure it really does, but it should be. The Joint Commission demands that anytime you do a procedure where there's a sidedness to a thing you're doing, you must mark the site. Basically what you do is during that scope 1, when you're with the patient and the team, you mark on the skin which side. So particularly if you're doing something where there's laterality, like a nephrostomy or a pleural drain or an AVM in the left leg, or because there's laterality, or if you're doing right and left skin punctures for paired organs, or if there are multiple structures like an AVM of a finger or a vertebroplasty at L2. You absolutely must mark on the skin in some fashion. And so just remember to do that. And if were you not to do that and something happened, you would be at serious liability. Timeout. I think you all know this. Again, the Joint Commission requires that we do these times out or whatever you want, the verifications of patient, what we're doing, who is this patient, is it really who we think it is? Do we all agree on what we're doing? And is that what was ordered? And then looking at all the elements that might be issues in terms of sedation and labs and allergies and so on. Remember that we are 2 scopes. Scope 1 is done by some physician or PA who's actually been involved with the procedure. It can be a resident, it can be a PA. Scope 2 must be done with the attending physician who's going to do that procedure present also. And again, in every room is the scope list, so you just go down the list. Now, what is a generally accepted radiation dose for fluoroscopy guided procedure that can lead to permanent skin injuries? So this is something you should probably know for boards. And patients can ask it too. So you want to know the answer. You should know the answer to this, just as a radiologist. The answer is 5 gray. So basically, when your total accumulated dose, and that basically that's going to be your air karma, the milligrays for the whole case, including fluoroscopy and all the stored images, when it exceeds 5 gray, radiation safety physics department will contact you. You don't have to try, you don't have to figure it out because they'll let you know probably before you're even done with the case. You did this procedure, more than 5 gray was reported, you need to follow up on the patient. Anything below that, and the likelihood of permanent skin injury is unlikely. Anything from 2 to 5, transient skin injury with erythema can happen. So that's when you may still want to let the patient know. So radiation safety, there are basically 2 issues. One is the patient. So again, 2 gray for transient skin, threshold for permanent is 5. The high-risk procedures, I think, are the ones that just take a lot of imaging, a lot of fluoroscopy. I think you know what all the kind of things you need to do, and these should become reflexes. Lead shielding as needed, particularly gonads in younger patients, always collimating the beam, limiting fluoroscopy and digital time. making sure that the detector, the detector is as close to the patient as possible. That minimizes scatter, obviously limiting fluoroscopy time, and adjusting the radiation area during long cases. So rather than imaging an AP for like 2 hours, move it a little bit. Radiation safety for you, wear your radiation badge. I think you all know this. I don't need to remind you, but you know, you're gonna, for those of you that are gonna be doing fluoroscopy a lot, a lifetime of this, minimize the patient detector distance, just make it a habit. Careful beam collimation, keeping your hands out of the beam, staying away from the beam. If you're gonna do injections in the room, then maybe get behind a lead screen, and then tube angulation to keep your body parts out.
High our stuff. Like, hey man, just don't blast a patient with radiation 2 centimeters above the skin.
Someone mute their, can someone mute their screen? Hello?
It's like,
Okay, thank you. All right, infectious disease precautions. Similar patients of HIV or HCV, meaning be very careful. As far as SARS, that has now changed. And so you don't have to worry about that. Universal precautions, I think you know all about that. Changing gloves when integrity is breached or every hour, that is actually ideal. Secure place for sharps, we're gonna talk in about a minute. Don't recap needles ever. You put them in the sharps container. And if a needle stick occurs, I do need to tell you to contact employee health. What you do is up to you, but that is what we are instructed to let trainees know. This is really important, particularly if you don't do IR all the time, if you're working in it, is that you do not want to be the person who caused a needle stick in a tech. And it happens every year or two that a resident, experienced or not, leaves a needle on the table and a tech gets stuck. And you would not want to be the person doing that. So during scope 2, we designate an operator in charge of sharps. So if you're that person, don't forget, at the end, you're responsible for getting them all off the table. But every operator is responsible for sharps management during a case. So never leave an unprotected sharp object on the field of the pack table, period. I don't care how quickly the case is going. Just don't ever, ever, ever do it. And every time you move a sharp, so you'll hear the residents and attendings when they'll give anesthesia and they'll finish with the anesthesia at the groin and they'll say sharp back. And what that means is I'm turning from the field to the back table with a sharp needle, get away. And you do that when you go forward. So every time you move a sharp, a needle, a blade, you will make, it's become just like habit, like putting on a seatbelt. You just do that to warn everyone. Always put anything sharp, you know, even if it's sharp like a metal stiffener, into this sharps container. At the end of the procedure, then you take the container and you put it in the big sharps bin. And then I go back to this, when I'm in charge of that, my job, I go back to the back table and I scan the whole table, kind of scanning for what did I miss? And every now and then, oh, I missed something. There's a blade there. There's a whatever there. Because you don't want to be the one that causes a needle stick in a tech. You will feel bad forever. Okay, now I'm going to talk about sedation. Obviously, you know, unless most of this is done by the nurses, but you need as the providing doctor, you're still responsible for actually administering these or ordering them. So you need to know what's going on. So you need to know about these drugs. So what's the interval between dose of midazolam or fentanyl for moderate sedation? So we give a dose, then how long do you have to wait before the next dose? In IR, it varies depending on what part of the hospital you're in. 5 minutes. So you have to wait 5 minutes after each dose before you give the next one. So these are the agents you got to know about because these are really the only agents we're allowed to use. Midazolam, Versed. So this stuff, if you're going to do IR, you need to know this by heart. It takes about 2 to 4 minutes for it to work, although in reality, it's really more like maybe 2. It's pretty quick. Its duration is up to about an hour. You usually start with 0.5 milligram or 1 milligram, depending on the patient's condition, mental status to begin with, age, weight, and so on. Typically 1 milligram, sometimes half. And you can repeat that every 5 minutes, giving incremental doses, either one or a half, depending on how they're responding. And you can give, the total dose doesn't actually matter. Once you get to about 5 and 250, you begin to worry that's a lot. Even 3 and 150 is a lot, but you can continue giving it depending on how they're responding. Remembering you need lower doses for certain groups of patients, small body mass, advanced stage, liver disease because of metabolism and so on. The other drug we use, fentanyl, is called Sublimaze. Onset 2 to 4 minutes, really more like 1 to 2. Duration is a little bit an hour, half an hour to an hour. Again, standard dose, 50 micrograms, maybe 25 in a smaller person or someone who's already drowsy. Again, repeat every 5 minutes. You will need higher doses for patients with chronic narcotic use or abuse, so be prepared. So this is how I like to do it, and every attending is different. Once you become an attending and you decide what you think is right for the patient. I tend to be more aggressive than a lot of them. I think, because after all, what do patients remember about procedures? They remember how much they remembered it and how much it hurt. They don't remember all the cool things you did. I mean, you're supposed to fix them. That's your job. You don't get many points for doing a nephrostomy. It's like, you're supposed to do that. All they remember is how did it feel? And so the way I look at it is, I want to do it. I want the patient to feel the way I want my mother or my sister to feel. Think about that every time, and that will kind of guide you on how to do it. But be honest about the discomfort. Don't tell them, oh, this isn't going to hurt. Well, it might hurt, so let them know. So it's just a generally good rule in IR: under promise, over deliver. This could really hurt, and then it doesn't hurt, and they're thrilled. Patients should be sedated before you begin, before it's somnolent. So when you give the anesthetic, they might respond and say, oh, it hurts a little bit, but they shouldn't be jumping off the table. If not, they're not ready. If a patient does become agitated because they're not properly sedated at some point, I just stop the procedure. I usually leave the room, I take my gloves off and let the nurse continue giving meds until you can get to a point where you can do it. The patient will not be uncomfortable. Continue, and by this, continue sedation analgesics, not giving the drugs, but having the effect to the very end, because they've actually done studies to show what do patients remember from procedure as far as pain. What they remember is how bad the pain was at the worst possible, at its maximum, and what was the pain like at the very end. And then finally, remember to provide adequate pain medication after the procedure when you're writing notes, so maybe oxycodone, or occasionally, if it was really uncomfortable, maybe some fentanyl. And then to end, I think we got good 5 minutes. So this is what you need to do if there's over sedation. Fortunately, this doesn't happen very often because we're just really good at doing it and doing it safely. But you need to know what to do. Having done this, some nurses will just immediately respond, and sometimes nurses have no idea. So you need to do it. Or if I'm the attending, I basically take off my gloves and I take over. If they basically stop responding, or their O2 sat goes down to 80 and it won't go up, or their PCO2 goes to 60, check their vital signs, get a new set of vital signs, give them oxygen if they're not getting it, and do it by face mask because they're not necessarily breathing through their nose, and maintain an airway. So I will personally take off my gloves. I go to the head of the patient, and I do one of two things. Now, if the nurse has already done this, great, but they may not, and you need to know how to do this. You either do a chin tilt or a jaw thrust. So either you tilt the chin back, chin up, head back, or a jaw thrust. And you can do either. Maybe if there's an issue with their cervical spine, you only want to do this one. But either way, one of these two maneuvers, both hands, gloves on, and you just wait there. And I've never in 30 years not had this work, actually. Well, maybe once. You just hold it there, you watch their sat, and it will go back up. And you just stay there. Usually takes 5 minutes, maybe a little longer. The drugs will wear off. They'll begin to wake up. They'll open their airway, and you'll be okay. That's all you do. Now, if it doesn't work, which very rarely doesn't, be ready to give positive pressure ventilation. So then if it doesn't work, then you're going to need to put on this ambu bag and deliver it that way. This is something that when you do our moderate sedation, at least at UW, every 2 years, the attendings have to do this. We have to actually go to And see, if you go to the OR and do this on a patient, that's really a good thing. I really am glad we have to do that. Rarely, maybe once in the 14 years, twice in the 14 years I've been here, if I've ever had to do this or seen it done. You got to know how to reverse agents. Again, if you forget the doses, they're written in the labs. But final question: in a patient requiring reversal of sedatives and narcotic agents, what's the initial dose of Narcan for fentanyl? Answer is 0.04, not 0.4, but 0.04 to 0.08 milligrams per IV. And that dose can be repeated every 5 minutes as needed. So secure the IV time, wait, open the airway and just wait. But if they're still not responding and their airway is closed and they're still hypoxic or hypercarbic, give a drug. For midazolam, you give flunazepam. For fentanyl, you give Narcan. And call for assistance if you need it. So post-procedure care, you got to write a note before the patient leaves procedure and make sure that whatever the plan is, you share it with the nurse. So the nurse leaving the patient, the nurse taking care of the patient in ICRU, and the family and the patient all on the same page about what you're going to do. Ideally, surgeons, they learn this. You do an operation and you walk out of the OR and you go and find the family and you tell them what happened. And then you go to your workroom and you dictate the note. That's what surgeons do. It's like they don't think about it. They just always do it. We're not very good about that. We aren't. And we should be. So certainly if the procedure was patient sick or the procedure was serious, really difficult, go find the family. It's kind of what they expect doctors to do. Make sure everyone is aware of the outcome and the plan. Arrange for future procedures immediately. So if it's, a G-tube and you need to remove the T-tax in 14 days or 10 days, arrange for it. See the patient before leaving that day if it was an inpatient. Continue seeing inpatients every day, and of course document interactions. And then finally, my little soapbox. Oh, almost. These are the fundamental principles of being a good IR doctor. Act like a good surgeon. Evaluate a patient's clinical problem and determine suitability for IR treatment. That is, act like a doctor deciding, is this treatment right or is there something else? Not a technician, I'll put in that filter, whatever you want. Start and maintain a relationship with the patient family. Isn't that why we went into medicine? Pre-procedure preparation needs to be managed well. Communicate and coordinate post-procedure plans with patient family and other providers. And finally, take responsibility for immediate and long-term care. And it is just 4 o'clock. So thank you, everybody. I don't know if you guys even have time or have questions, but I'm welcome to answer them. And if not, I think you have a talk after this.
If you are able to send out a PDF, that would be great.
I will do that. Who should I send it to? Marcus or Trixie or?
I bet Marcus would be able
Yeah, you
to
can send
share
it
it
to
with
me.
all of us.
Yeah, I can get it out to everyone.
Thank you. I will send a PDF of this, Marcus. You can distribute it to all UW radiology residents.
NVM, please, too.
Oh,
Okay,
VM, yes.
sure. All right.
Thanks for joining us, VM folks. Great to have you.
Thanks for teaching us.
You're welcome. All right. Well, I'll let you all go. Have a great day. Stay healthy. See you on
Thank
IR.
you so much.
You're welcome. Bye-bye.
Thank you.
Thank you.
Thank you.
Hey, and this is George. I'm here. Do you guys want to take a little break or just get it over with?
Let's keep trucking.
All right, stand by. Let's get a little slideshow. All right, can you guys see that?
Yep.
Okay, so I've also got a bunch of questions that we used to get to have fun responses to, but this time just I was going to use the chat, but I think that may be just a pain in the neck for everybody. So if you want, just unmute yourself and shout them out. Okay.
Dr. Soltes, I can set you up as the host if you want to run the polling, if you're familiar with that in Zoom.
I think I won't
Okay.
try to do that on the fly, but thank you. I'll learn how to do it for next time. So first of all, I got to hear the last bit of that lecture. Karam is amazing, and we're all lucky to get to hear it basically from the textbook. So my the topic I've been asked to give is about venous access. And, many of you guys aren't going to end up going into IR, but anybody that basically goes into private practice in any kind of radiology role, chances are you're going to be doing venous access and probably going to be doing a lot of it. So my first quiz question is, over the last 20 years, the number of long-term central venous access devices placed by radiologists in the US has decreased, increased by 50%, 100%, 300%, or 20,000%. So using normal test taking skills, if I didn't know, I would have probably said C or D, but actually the answer is E. It increased over 20 years in one study by 20,000%. So previously, before say the early 2000s, most venous access was placed by surgeons in the OR, or short-term access was placed by anesthesiologists. However, IR has increasingly taken over this practice. Just to show you the same study, which I've really never been able to find anything more recent, but about a 20-year period from the 1990s to the 2010s, this is temporary central venous access. The percentage by radiology increased 11,000%, whereas surgery and anesthesiology went down. And for long-term central venous access, which basically means ports and tunneled catheters, as we said before, it's gone up 20,000%. The number of procedures has also increased, but radiology has just taken this over, probably more than any other thing we do in our sort of turf war scenario. This is something we've just decimated. And why is that? The truth is, because we do it better, we do it faster, and we do it cheaper. We can get patients done fast. We use imaging, which is what makes us special, to do it better. We're doing it in our procedure rooms instead of in an OR, and generally without an anesthesiologist. So to help you guys do it better, faster, and cheaper, today we're going to talk about how you choose an appropriate access device, what route you choose to get it into the patient. And once we place these, we kind of own them. So assessment, prevention, and treatment of complications. So there's a whole bunch of access devices out there. So how do you choose the one that's appropriate? And I'll say at the beginning, kind of what Karen was saying at the end, be a real doctor. They order all kinds of things. They're often order the wrong thing that's not best for the patient. So we're truly the experts on these things. So selecting an access device, there's really just a couple of questions to ask yourself. What is it for? How long will it be needed? How often will it be used? And what are any lifestyle considerations of the patient? Placing one on a 95-year-old in a nursing home may be different from in a 20-year-old or a toddler, say. So this is sort of the gamut of devices, all the way from peripheral of IVs to ports. But we're not going to talk about all of these. We're going to focus on PICCs, tunneled catheters, and ports. So I'm going to start with tunneled catheters. All this means really is that it's a catheter that has a cuff, and that there's a tunnel under the skin between where you get into the vein and where the catheter exits the skin. And these are used for a long period of time, usually measured in months, with frequent access, often used daily. So periodically in this talk, I'm going to bore you guys with some of the history because it's surprisingly colorful, and I think some of it's kind of hilarious. So bear with me. So the very first ever central venous catheter was placed by a German physician named Werner Forssmann in 1929. It was kind of controversial. People thought it was a terrible idea and they forbade him to do it. So he literally tied up his nurse to a chair and placed the line in himself. And what it basically was sort of a early version of a PICC line. He put it in an antecubital vein. He threaded it to his central veins. Then he untied his nurse and they walked over to X-ray and got an X-ray to see where the tip of it was. This tended to be a sort of a pattern with Werner, and he ended up publishing his memoir, which he titled in a very matter-of-fact way, Experiments on Myself. Werner Forssmann also did a few other things, including inventing cardiac catheterization, for which he won the Nobel Prize in 1956. So the advent of tunneled catheters specifically was a real game changer in medicine. Before these catheters were invented, it was very difficult to take care of patients that needed long-term access. All that existed were, as far as catheters went, were temporary stiff catheters, and these required a whole lot of special care to try to extend their life. This was from an article in 1969, the daily routine for taking care of these catheters, which involves defatting and ether and acetone and scrubbing with tinctures and all kinds of stuff. Otherwise, for longer term access, the only option was surgically placed AV shunts or AV fistulas. So the game changer for tunneled catheters was in 1978 when this article was published describing the first widely used cuffed tunneled catheter. It was developed by Robert Hickman, who was actually a pediatric nephrologist, but became interested in venous access, who was right here at UW. He's a pediatric nephrologist, and he placed these day in and day out at SCCA. And this was really a revolution in delivery of medications, IV fluids, blood, and nutrition, particularly in children who needed TPN. Unlike Werner Forssmann, Hickman was notoriously modest and kind. And the quote when they asked him about why it was called a Hickman catheter is he said, they had to call it something. They named it after me because they didn't think it was going to work. So here's the next quiz. This involves French size. So I want you to think about this in your brain since I'm not getting feedback. So a 6 French catheter has an external diameter of 2, 3, or 6, or an internal diameter of 2 or 3. You know, we're always talking about all of our catheters in French size. And the answer is an external diameter of 2 millimeters, which we'll get to. So now talking specifically about tunneled catheters, they vary in size from small to really big, with the bigger ones usually being used for dialysis. Little deep dive into French size. I think it's a really weird metric, and catheters in general have a lot of metrics. They're measured different bits of them in inches, centimeters, and French size. So what the heck is French size? Last little bit of history. It's a measure, first of all, of the external diameter of a catheter. Why is it called French size? Was there a Dr. French? No, it was just named after a guy who was French, who had a very long name with lots of little symbols over the letters, which you can see there, which I won't try to say, back in the 19th century for all sorts of round things. And the bottom line is a French equals a diameter of 1/3 of a millimeter. So basically you divide French size by 3 to get the external diameter in millimeters. So that's why a 6 French catheter, if you measured its diameter with a little bitty ruler, it'd be 2 millimeters in diameter. Tunneled catheters are made generally of 2 different materials, silicone or polyurethane, which we'll do another little deep dive in a little bit, with a cuff usually made of Dacron, which is meant for your tissues under your skin to grow into and kind of attach themselves to. That was Hickman's big innovation. These are accessed via a central vein, which we'll also talk about. Advantages of tunneled catheters over other devices: they're relatively easy to place, and a lot of different practitioners know how to place them. When they need to be used, you don't have to poke on the patient. And as we talked about, they can be made quite large to allow high flow. Disadvantages: it's a central vein, so they entail the risks of central venous puncture, which we'll get into. You've got a catheter dangling out of your body somewhere, so that limits activities. And they require daily maintenance, namely dressing changes and usually daily flushing, which is annoying. So a quiz: micropuncture system, which if you guys have done IR, that's what we generally enter your body with. So what does it consist of? An 18 gauge needle with an 018 wire, or a 3/5 wire, or a 21 gauge needle with an 018 wire, or a 3/5 wire? Tick, tick, tick. Answer is a 21 gauge needle and an 018 wire. So this is just some little photos that I took of placing a central tunneled venous catheter. So like we do pretty much everything now, we access the vein under ultrasound visualization. And on the left, you can see, your two hands holding an ultrasound probe and needle, in this case, I guess numbing up, or maybe there's a syringe on there to aspirate blood. I can't remember. And here's the needle going into the internal jugular vein. And there's the carotid over there. And micropuncture system, 21 gauge needle, a little bitty 4 or 5 French sheath and an inner dilator. When you remove the inner dilator and the wire, it transitions up to a 0.035 inch system, which is typically what we work over. So it allows you to go in with a little bitty system and then transition up to a larger working system. So once you're in the vein, your wire's down. This is like vintage, the original Hickman catheter with these goofy plastic tunnelers. So now we're tunneling between the chest wall and our venotomy site. Peel away sheath goes down, catheter goes through, and you end up with your finished product. So if you do IR here, UW has very wisely avoiding putting in PICs, but this is another thing where in a normal practice, this is something you're going to very likely participate in one way or another. I think, so I'm going to devote a little bit of time to this because I think they're important and sometimes misused. So first of all, just some definitions. So PICs are used for frequent accesses over an intermediate period of time. So usually shorter duration than tunneled catheters, more in the 4 to 6 week range, with a typical scenario being someone that needs 6 weeks of IV antibiotics, say for osteo or something like that. They're much smaller because they're going in smaller veins, 3 to 7 French, usually 5 or 6 French. And they can have anywhere from 1 to 3 lumens, usually most often 2, like we show here. And you access a vein in the upper arm, which are namely the basilic, cephalic, and brachial veins. Some are better than others, which we'll get into. So advantages, they're cheap. There's not too many complications because there aren't big scary things to poke for the most part. They don't get infected very often. They're easy to revise. They're easy to remove. There's no cuff, so you pretty much just take them out. And we'll also talk about this a little bit. They don't have to be placed with fluoroscopy. They can be placed at the bedside by a vascular access team. Many disadvantages, though. They're small and long, so they're hard to draw blood from. They have to be flushed a lot for the same reason. It's a very narrow, long lumen. Since they're out on your arm, which flops around more than your chest, they're more likely to get pulled out by accident. They're more likely to occlude because they're teeny. And we'll talk about it in a little bit. They cause a lot of venous thrombosis. So here's how we place a PIC. The orientation is a little different than central lines and ports. So here on the left is a nice ultrasound of the upper arm. In this case, showing the Mickey Mouse ears, which is the brachial artery and the paired brachial veins, and then medial to them, this nice big juicy basilic vein. As you saw on the IJ axis, we usually access the IJ in a longitudinal plane where we have the vein kind of splayed out, but we usually do arm veins in a transverse plane because they roll around kind of too much to keep them in plane. So here you can see a different sort of orientation of our needle coming straight down from the top into the basilic vein. So now we're in a big old long 018 guide wire goes in. These completely go in over an 018 systems. There's no micropuncture. The wire has a little measury thingy on it. So you cut your PIC to appropriate length. You put in a little peel away. PIC goes in, peel away goes away, and there's your finished PIC. So as I mentioned, these can be placed at the bedside, which is a huge boon. And these nurses do an amazing job with it because we pretty much need fluoro for most everything. So it takes a little longer, sometimes takes a few more sticks, gets into a few more adventures, but by and large, they do quite well placing these at the bedside. This is what I wanted to kind of take a little detour here because I have this theory that PICs are like zombies in that they tend to proliferate. And the more you try to stamp them out, they just produce more PICs and more zombies. So I wanted to kind of spend a minute and talk about my experience back at my private practice as maybe a bit of a cautionary tale and an approach that we finally painfully came to. So I call this World War P because reminded me of World War Z, the amazingly underrated Brad Pitt zombie movie. So At our hospital, initially IR placed all the PICs in the angio suite. And we found the demand was increasing. We placed about 150 to 200 a month. Even though we triaged them all, we gave people a hard time, whatever, it was still a lot of PICs. And since we're doing all kinds of other procedures that we'd rather spend our time doing, we tried to figure out a way to decrease this load. So back in 2004, we established a nursing PIC service run by IR that taught nurses to go up on the floor and place PICs. So we followed this very closely, how many PICs per month our nursing service was placing, and we were still placing in IR with the idea that we'd place the ones that they had some difficulty with or where there was some complicating factor. So in the first year we did this, the nurses placed 370 a month, the next year 475 a month, the next year 590 a month. And we found we were still placing as many as we ever did, just the pie had gotten much, much larger because when they're available, people wanted them and they proliferated because it's a great convenience. So we ended up with total PIC load going from 150 to 200 a month to over 700 a month, exactly the opposite of what we wanted. You might ask like, well, so what? That's a lot of procedures, raking in the Benjamins, like they say on Breaking Bad. But as we alluded to before, there's a problem, which is PICs are very, very, very bad for veins. PICs, if you just think about it, they're going through little bitty veins for a very long way. And it turns out they cause a lot of thrombosis. And there were tons of studies as PICs were sort of proliferating in the early 2000s to look at both symptomatic and asymptomatic thrombosis. So just symptomatic, somebody's arm swells up, is somewhere between 1% and 4%. But if you looked at all thrombosis, having one PIC, about a quarter of patients will have venous thrombosis, which goes up to about 40% with multiple PICs. There were a lot of factors that were sort of surmised to make a difference. One thing that seemed to be consistent is that the cephalic vein caused more thrombosis, which if you know the anatomy, it kind of curves around and is the longest of those veins in your upper arm, kind of makes sense. So if you're placing PICs willy-nilly in all comers, because it's a convenience, you're thrombosing a lot of people's veins and people that need a lot of venous access, dialysis patients, patients with chronic diseases like cystic fibrosis that are getting multiple devices, that can be a problem. So in 2007, we kind of revisited it. We reinvented our IR nursing PIC team as a vascular access team that would place not just PICs, but also bedside ultrasound guided IVs. And most importantly, we established strict criteria for PIC placement. I won't go through all of these. These are easy to find. The main take home is that they needed an actual indication for a PIC as opposed to just an IV, long-term care, things you can't give through peripheral IVs like vesicants and TPN, things like that. And they didn't have any of the contraindications, the most important of which is end-stage renal disease. Because if you trash a patient's arm with a PIC who has dialysis, you may have lost them like 10 years of dialysis. When we did this, we found that it worked. It takes a lot more effort because you have to triage everyone, but we got our PIC use down from 700 a month to around 200 a month. So the bottom line for the strategy, only place PICs if they're indicated, not as a convenience. Provide a service that provides an alternative, namely ultrasound guided IVs, instead of just telling them good luck. And most particularly, don't place PICs at all in patients that have end-stage renal disease, which is one of the DOKI or KDOKI guidelines. And in general, or completely avoid use of the cephalic vein. So we'll move on for PICs now to ports, my favorite device because they're cool. So a port is a fully implantable venous access system. There's nothing that hangs outside of the skin at all. It's meant for access over a long period, but infrequently, with the typical case being a patient getting chemotherapy that may need their port or their device for a year, but is only getting accessed every 3 or 4 weeks. They come in a few flavors, central or peripheral, single or double, and some other flavors we'll talk about. And they're kind of medium catheter sizes, usually 6 or 8, some bigger ones for more niche uses. And the ports are made of metal, titanium, or stainless steel or like this one in the picture made of plastic. So a little bit of history once again, because it just shows how, to me, how kind of ingenious people are. When there's a need, they figure out a way. So in the very early 70s, the very first port, there were no commercially available ports, but there was a need, in this case for TPN, because remember, this is before Hickman came along with his catheter. So in this case for pediatric TPN, this Dr. Balin basically used an Ommaya reservoir, which you can see pictured up here in this cool old picture, put it under the skin, invented a needle that worked with it, and basically created the first port. The first commercially available port was about 10 years later, or exactly 10 years later, at my very own MD Anderson in 1982, which it's kind of cool to compare. It was called the Infusa port to ports now, because it has a very big body and a very teeny septum. And it was used, as we mostly use ports now, for chemotherapy. Peripheral ports, the first one was in the early 90s called a periport. And then the first one that really took off that still exists was a passport, which were initially placed in the forearm, but now we place them pretty much exclusively in the upper arm, so they're not going across your elbow joint. So advantages of ports are many. They can't be dislodged. There's nothing sticking out of your skin, so it's pretty much impossible to pull them out. Most importantly, they're much easier to live with. Patients, once they're healed, they're completely unlimited in their activities. Since nothing's hanging out for bugs to crawl up, they have a decreased risk of infection. And again, very importantly, if you're living with one of these, there's minimal maintenance. They only need to be flushed once a month when they're not in use. Most people will be using them more frequently than that. So they use them, they flush them, and they're good usually till the next time. Disadvantages, they're expensive compared to other devices. You have to have some expertise to place them and to remove them and to generally deal with them. They're limited somewhat by their size, so you can't usually get the very high flow rates of big external catheters. And if you're placing them in a patient that's going to need access every day, you pretty much negate most of the advantages of having a port in the first place. The other thing is, to access them, you're not just hooking up to a catheter, you have to have a place that knows how to access them sterilely and has the right types of needles and stuff, which we'll get into in a sec. So briefly, we don't place a lot of peripheral ports here, but it's a very regional situation. Like where I came from in Texas, our service placed more peripheral ports than chest ports. So it kind of depends where you're at. So you could see these where you're going. Bottom line, this diagram on the left shows typically where we place them, kind of mid to lower third of the upper arm, and they terminate in the same place as a chest port. And they're pretty similar. They're just a little sleeker. They're smaller, less fat, and less big around. Central versus peripheral, very briefly, central ports, they're more universally used, so people are more used to accessing them. They're bigger, so they're easier to access and decreases the chance of, misadministration of chemo or other things. And they're bigger, so they have a higher flow rate. They also have a lesser risk of thrombosis because, much like the PIC situation, the peripheral ports are going through a lot of vein to get where they're going. Peripheral ports, mainly it's a patient preference thing. They're more cosmetically appealing. We placed a lot of these in my old practice on breast cancer patients who already may have a scar and almost certainly have surgery on one side of their chest and are anxious to have stuff going on the other side. Some patients like using them better. You just sit there and throw your arm out instead of disrobing for a chest port. And you avoid the complications, which we'll get into, of central venous puncture. Briefly, ports are accessed with a special needle that's a little different than a hypodermic needle. It's called a non-coring or Huber needle. And the things, and you can see it pictured here, the thing that makes it kind of neat is the bevel, the little hole in it. Instead of like an IV needle or almost every needle we use, it's not on the end of the needle, it's on the side, which means that the needle's not coring a hole through the little rubbery septum of the port, which is why they can take usually around 10,000 sticks before they start having any issues. Placing a port is exactly like placing a tunneled catheter with a couple of extra steps. Here we are, or I am actually accessing the vein under ultrasound. I now have a little wire down, and instead of just tunneling, you make a pocket, open it up, make it big enough for the port, tunnel the catheter between the pocket and where you access the vein, put down a peel away sheath, and then put the catheter down into the vein. At least you can do these in a few different orders. I attach the port last because I don't like measuring things, so I can just pull it back to where I want it, attach the port, stick it in the pocket. Some people secure the port with some sutures that you see here. Here, generally on IR, we don't. The worry is that the port will flip, but usually if you make kind of a snug pocket, it doesn't. Now everything's in and you make it beautiful. I heard the end of Karim's talk where he's like, patients judge you by how much they hurt. They also judge you by how pretty their scars are. So it's worth knowing how to sew and make them pretty so that they'll love you. And there's the completion chest x-ray. In this case, you can see the Huber needle is in place. There's the port and a nicely placed port catheter. So pretty much done with the different kinds of devices. For the last part of this part of the talk, before we get to complications and such, wanted to talk about some special cases, gizmos and gadgets. Namely, the material the catheter is made out of, different kinds of valves, various kinds of coatings that are supposed to prevent infection, the power access, and finally, the newest thing, apheresis ports. So catheter material, like we mentioned before, most catheters are made of silicone or polyurethane. Silicone was what the original catheters were made of. They still make them, the original sort of old-fashioned Hickman catheters. Traditionally, it's felt to be more biocompatible than polyurethane. The early polyurethane especially was quite thick and stiff. But the newer polyurethanes, the material has been developed so that it's much thinner, and in fact thinner than silicone, so you can achieve a greater lumen size with the same size catheter. And newer generation polyurethanes are felt to be equally biocompatible to silicone. So to my mind, they offer a lot of advantages and pretty much no disadvantages these days. A big thing, and I have to resell this all the time at SCCA and other places where they've had this drummed into their brain, is that things with high concentrations of alcohol, some chemo regimens and other things will like cause polyurethanes to break down and basically break or fall apart. The newer polyurethanes, this just isn't true. They're just as compatible with alcohol, but this kind of resurfaces every couple of years. And there's really, at the end of the day, no conclusive evidence that one material is better than the other. I typically go with placing the smallest thing I can get away with the same lumen size. So in general, I prefer polyurethane catheters. So getting into some special cases, wonder if any of y'all know what a Grishon catheter is. You still see a lot of them out there, and you'll recognize them on chest x-rays. It's a special catheter. Does it have an antibiotic coating, a special fancy cuff, a distal valve, a proximal valve, or is it some kind of hemodialysis catheter? So we'll see in a sec, a Grishon catheter is a catheter that has a valve built into the distal tip. So now getting on to valves, there's basically, these come in two types, distal or proximal. Grishons have been around forever, and they have this little slit at the end instead of an end hole like most catheters that opens or closes when you're flushing or aspirating, when you're either decreasing pressure within the catheter by flushing, by aspirating, or increasing pressure by flushing. And proximal valves, also known as passive valves, are built into the external trailing end of the catheter. And passive stands for pressure activated safety valve, which are a little bit newer innovation. So the idea, as I mentioned, is the valves only open when you're flushing or aspirating, with the idea being that instead of just an open catheter, that blood can't get into it or air and cause clogging or other issues when it's just hanging out. However, this worked better in theory than in practice. Grishon catheters have been studied a lot and have not been found to really have any advantages. They actually, as it turns out, get into problems more often than open catheters. We'll talk in some point in our complication part about fibrin sheath, which forms on the outside of catheters and tends to clog up these little slits. And then when we have to fix them, when they don't work, they're kind of annoying to work on because there's no end hole. So if you're switching it out over a wire, you got to manipulate your wire out those little slits, which is annoying. Passive valves, the more newer thing. maybe a gimmick, maybe not. They're, as I mentioned, built in the end of the catheter, or they also make ports with these. The selling point is that they don't require heparin because these valves are keeping blood out of the catheter. They, of course, cost more. And studies that have been done over the last 10 years haven't really shown that they help. Antiseptic catheter coatings. So these have kind of, over the last 10 years, have started to be used more. So what has the science shown? Have they not been effective at all? Have they helped in short-term catheters, long-term catheters, or both? And it turns out the data shows they've helped with short-term catheters, especially in an ICU setting. They really haven't been studied much in long-term catheters like what we're talking about today. So what these catheters have is either an antibiotic coating or a chlorhexidine sulfur sulfadiazine coating. And actually they work rather well in ICU catheters. If you look at them, they look different. They're kind of this ugly, milky brown kind of color. And in short-term non-tonal catheters, they've significantly reduced bloodstream infections, which is a big deal. And again, the jury is still out on ports or tunnel catheters. Nobody's manufacturing them so far, so it's a little bit of a moot point right now. Now I'm going to talk about power access, which we use all the time. Could it be marketing? Could it be real? It's real enough that pretty much all the things, especially all the ports and a lot of the tunnel catheters we place, are power access. So what is this? BARD is, lots of people make them now. BARD came up with the idea first, and they're recognizable because they're all in fairly smart marketing, this nice purple color. And even other manufacturers that make power things now also made them purple because people associate it now. So they're for everything, picks, lines, ports. And they allow the big deal. I don't know how big of a deal, but the thing they do that's useful is they allow CT contrast power injections. They can take up to 5 mils a second. And for ports, they need a special power injectable needle so the needle doesn't explode or blow out of the port, etc. And the final thing I'm going to talk about, which is really new, we've only been placing them about a year, are pheresis ports. And these are fairly niche. They're for patients which are more and more common who require chronic apheresis. Really, the only other way to get apheresis is through a big dialysis kind of catheter. So they're kind of neat and kind of clever. So they're kind of shaped, as you can see in the diagram, like a little funnel. And you access them with just a normal IV angiocath, a big 16 or 14 gauge IV needle. It slips in there and there's a little stop that stops your needle. Then the little catheter bit goes on in through a valve, and they can achieve very high flow rates for pheresis, like 120 mils a minute. Of course, they're also power injectable. So we've been placing these mostly at SCCA for these chronic pheresis patients, which is really nice. So they don't need a big giant catheter. So now we're going to move on to our next topic, which was, we've got all these cool devices. What's the best way to get them into your patient? You know, I always talk about the veins we use for both access and for every procedure we do, the veins, arteries, and other things is sort of our on-ramps to the body. So what's the best on-ramp for these guys? So a couple of categories, central versus peripheral. Central being jugular, subclavian, femoral, and other more unusual sites that I'll talk about that come into play. And then peripheral being the things we talked about in the arms usually. So we kind of touched on jugular versus subclavian. Most of the data on this is from dialysis, hemodialysis population. Most of it was done in the 90s and 2000s. But in this population, at least, it's very definitive that subclavian catheters cause a whole bunch more thrombosis and venous stenosis than do internal jugular vein catheters. It's pretty dramatic, as you can see. All comers, about 50%, and symptomatic, which can be bad symptoms, 10 or 15%. And especially in the dialysis population, this is a very big deal. So when, surgeons that trained before the 90s, almost universally were trained to do subclavian accesses. They were taught all the bony landmarks and such, and that's what they know how to do. A lot of older surgeons, it's still what they know how to do, and people tend to go with what they know. but younger people and almost all IR people now try to stick to the IJ for this reason. There has been a more recent study that showed that while there were fewer mechanical complications, catheter dislocations, and malfunctions with the IJ, this particular study didn't find a significant difference in infections and thrombotic complications. You know, lots of other studies and most IR people's, their personal experience would say otherwise. So once you decided, hey, the IJ is awesome, which IJ do you choose? So a rule of thumb for all of these things, and I think why most of these things are true, is veins get sad when your catheters go around too many curves. I think they touch the wall more, they cause the veins to get sad, develop intimal hyperplasia, and that leads to thrombosis and stenosis and occlusion. So if you know your anatomy, here's your basic venous anatomy. The right IJ is great because it goes straight down. And there's been plenty of studies that support that. So bottom line, IJ versus subclavian, IJ wins with an exclamation point. Of the IJs, the right IJ is the best. So this happened to come up recently as, so I decided to throw it in the talk. So here's just the kind of patient we see every day, 41-year-old female with end-stage renal disease. They wanted a tunnel dialysis catheter, a fistula had gone down and she needed access. She'd had lots of catheters in the past. So here's our typical ultrasound of the right side of the neck. There's the IJ, there's the carotid, which lives just deep to it. So it looks pretty good, right? As we were looking with ultrasound, once we scrubbed in, we're like, yeah, the IJ looks a little sketchy down deep, but we'd already prepped the patient. It's super annoying to unprep a patient and move everything to the other side. So we try at all costs to stay on the side we started. So we decided just to go for it and hope for the best. We accessed the vein without any trouble, but our wire wouldn't go down. So we shot a venogram through our needle, and sure enough, here's our needle, and here goes our contrast. Instead of going straight down, the IJ is occluded, and it's going around this little crazy collateral, ultimately down into the chest, which probably wasn't going to work for a big dialysis catheter. So what are we going to do? What do we do now? So just thinking for yourself, do we want to do a left IJ? Do we want to do the right external jugular vein, the right subclavian, do the femoral vein, just quit IR entirely and go home and go into something else? What do we do? So here's our initial ultrasound again. So what about this guy? That's the external jugular vein, which looked nice. You know, in the moment, I wasn't really sure if that was the right thing to do for a dialysis catheter or for any catheter, but we went for it anyway. Like I said, we were already prepped. So there's our catheter. It looks nice. Everything looks great. So as we often do, sort of shoot first and ask questions later. Once we put it in, we decided to look at the literature and see if we did the right thing. And of course, found these hardy Koreans that had studied exactly this question. And sure enough, our laziness paid off and we were right and found that the right EJ is preferable to the left IJ when the right IJ isn't usable. And femoral vein, is it any good? Not really. It causes more, it lives where there's a lot of sort of infecty things coming out of your body. There's more complications, worse patency. Patients hate it. We try to avoid it whenever possible. However, especially in dialysis patients or lots of patients that have had chronic access, it's not always avoidable. And then finally, what if you get a patient that has no upper body veins and no lower body veins? Jeff Chick's not available to build them new veins, or you don't have time to wait for them. What are some alternatives? So just for a couple of slides, I'm going to talk about transcollateral veins, translumbar, and transhepatic veins. So just an example of transcollateral, this was our old PIC service. You can see this patient has some sort of actually a chronic Grishong line. So there's the Grishong tip. Subclavian, which is just murdered as subclavian, but has this big giant collateral going around. So we just drove our PIC around that collateral and placed it that way. As I mentioned, a lot of dialysis patients can have complete loss of upper body venous access. So we can also place catheters directly translumbar, which means just sticking the inferior vena cava directly, or through the liver, transhepatic. We did a lot of these in my old practice where we had a lot of what we call end-stage access patients. You use these accesses when everything else is exhausted. As it turned out, we were just placing these right and left, and it turned out we had the largest numbers that had been reported. So we reported it. We reported 127 placements. We found they're not great. You're more likely to get dislodged or to migrate. They can prolapse by the liver. It can bleed. You can't really hold pressure on the hepatic vein. So, they're not perfect. However, and they require more maintenance. You have to fix them more. But we did find it was keeping patients alive, and we could keep long-term catheters in these patients over years. So in general, in summary, the choice of access site, we love the right IJ, then the right EJ, left EJ, subclavians, then femorals, although you might flip that in dialysis patients where you're definitely trying to preserve the subclavians for fistulas and grafts, and then the crazy stuff after that. The last thing we're going to talk about in terms of site is where you want your catheter tip to be. So just think about this. Do you want it in the mid SVC, the distal SVC, SVCRA junction, in the middle of the right atrium, or deep in the right atrium? And I'll bet you a lot of people would say, and a lot of referring physicians would say, C, SVCRA junction. Actually, that's not true, as we'll just get into here for a couple of slides. Even if you look at the IFU for these catheters, those little instructions that come with it, the Hickman catheter has a very strongly worded IFU that this is not a right atrium catheter. If you put it in the right atrium, you might as well just take a gun to the patient's head. You're going to cause arrhythmias, erosions, cardiac tamponade. Don't do it. Put it at the junction of the SVC and the right atrium. Still, though, that's wrong, and this slide shows why. These are two side-by-side x-rays of the same patient with the same catheter, which is happens to be a Power Hickman. And if do some little arrows, there's the catheter tip supine in the mid-right atrium. However, when they're upright, it's at the SVC-RA junction. So when we place these catheters, the patients are supine. However, most of their life, they're not supine, including usually when they're getting treated, they're sitting up. When you sit up, the external portion of the catheter is attached to the soft tissues of your chest. Gravity causes those soft tissues to go down, more on larger people, more on women, which, this being of a finite length, causes the tip to pull back. So if you start with this picture on the right that looks perfect, supine, when the patient sits up, that catheter tip's not going to be where you want it. So you want it, in general, on average, they migrate up about 3 to 4 centimeters, but more in bigger patients. So the optimal position when the patient's supine, which they always are when we're putting these things in, is the upper third to mid portion of the right atrium. In general, flopping around in the right atrium causes less catheter obstruction than being in smaller veins. And unless you leave it crazy long, arrhythmias are rare. And with modern catheter materials, a lot of these things, if you dig down where they perforated things, were really old, really stiff catheters. It basically, never say never, but basically doesn't happen with modern catheters. So I'm going to go really fast through access complications and try not to be repetitive in the next 15 minutes. So in general, big picture, these complications are either procedure related or delayed. For these types of procedures, immediate things, many of them are poking things you shouldn't, pneumothorax, air embolism, letting air get sucked into your device, hurting other things like arteries, bleeding, and delayed, usually infection, access malfunction, and some of the venous complications we've alluded to. So pneumothorax, here's a something you all see, subclavian catheter, big giant pneumo. These days with ultrasound guided IJ access, again, never say never, but we should never be causing pneumothoraxes when radiologists place catheters, bottom line. If you see one, hopefully one that somebody else caused. In all of my talks, I have this OF versus NOF terminology, which means our fault and not our fault. So hopefully, if we're treating pneumos, they're ones that are not our fault. If it's small, you can usually watch it and wait for it to go away. If it's not small, you can put in a pretty small chest tube. Different from our chest tubes we put in for pleural effusions. We put these in the front at the second intercostal space anteriorly, and they can be pretty small because air is very small. Air embolism can happen. It's less common with modern valved piloways, like the old Hickmans still come with just old-fashioned piloways that don't have a valve. So I usually make a poor man's valve just using a hemostat. You'll see it on fluoro and get scared. If it's symptomatic and if it hasn't already gotten into the pulmonary artery, you can do what's called a Durant's maneuver, which is Trendelenburg and left lateral decubitus to try to prevent an airlock. However, usually by the time you see it, it's already bubbled its way through to the pulmonary artery, like you see this one here in the pulmonary outflow tract right there. If they're having symptoms and you've already got your line in, you can actually try to suck out the air. But in general, sometimes the patients will drop their sats and scare you. In general, they do fine just cranking up the oxygen and giving them some fluids, and it almost always just goes away unless it's just massive. Other injuries, hopefully again, NOFs. This is a subclavian subclavian vein catheter, and a patient developed a hemothorax, and we did an arteriogram, and you can see the internal mammary artery is bleeding. So we got in there and blocked it up with some coils. Now we're going to talk about infections. So specifically, here's a question about port pocket infections. Usually you give them antibiotics, obviously. So is that it? Do you replace the port? Do you remove it and close the pocket? Do you remove it and not close the pocket? Or do you just sort of do nothing? Because I couldn't think of another one. And the answer is, hopefully you knew, is in general, you remove the port and you leave the pocket open. So here's a good example of that. Sadly, probably the incidence in all ports is around 2%. So it doesn't happen often, but we put in a lot of ports, so we see it. So in general, for accesses, infections can involve the exit side of a catheter, the tunnel, or the pocket, as in this case, or can be bloodstream infections. Usually it's staph or other gram-positive aerobes. Again, early or late. Early, we sort of blame our intraoperative sterility. Late can be because it was accessed in an unsterile way, because bugs crawled along an external catheter, or because it's seeded from some other hematogenous source. These catheters develop what's called a biofilm, and there's all sorts of theories about how that leads to catheter infections. We prevent it by using great sterile technique. Karam has alluded to kind of us being surgeons, and especially early on, there's a lot of controversy that we wouldn't be as sterile as an OR, so we try to be more sterile. We've talked about the antimicrobial coatings and short-term catheters. People have done studies and we've achieved what we wanted. We're just as sterile. We don't have any more infections than the OR. And then once the catheter is in, you adhere to dressing change and site care protocols. All the little goops and ointments haven't been proven to help. And there's some situations where you may use prophylactic antibiotics. Early on, when IR first started placing these, we did it a lot. It hasn't been shown to be helpful, and obviously giving people antibiotics for no reason isn't a great practice. So these days, we'll usually give a little blast of antibiotics for patients with really low neutrophil counts, or sometimes patients that have a history of having problems with infections. Treating it depends on the organism, the extent, how much the patient needs the access, and their overall medical condition. Little infections can usually resolve with just antibiotics. Tunnel and pocket infections, you often need to remove the device. Only 25% will resolve with just antibiotics. And as I mentioned in the question, port pocket infections, usually you have to remove the port, pack the pocket, and then arrange or teach the patient to remove the packing every day and repack it until it heals by secondary intention. Just bacteremia, with no external infection, is it kind of a different can of worms? Traditionally, we've removed the catheter, given them antibiotics and what they call a line holiday, let everything clear and then put it back. This can be a problem, especially for dialysis patients who have limited sights who obviously need to be dialyzed. And every time you're messing with these, you're potentially causing problems with their veins, which we'll get back to. There are patients that are prone to these. They can do antibiotic or ethanol locks, which are supposed to kill that biofilm that we talked about. However, if accesses are resistant, you still will need to, if the infection's resistant, you'll still need to remove the access if it doesn't clear with antibiotics. Oftentimes they want you to send the catheter tips or ports for culture. This is worthless, but we can do it to humor them. I'm going to breeze through complications, which basically are malposition, fibrin sheath, venous thrombosis, and venous stenosis or occlusions. The latter two, it's pretty much the same causes. So we'll go fast and then finish with pinch-off syndrome, which is just fun. So malposition, this is kind of an important slide. This was as you can see, a subclavian port, so almost by definition, placed by a surgeon. This is an upright film, so you can see how low the port is on their chest. This is a woman, so the port is dropped down, and now you can see where the catheter tip is. This port was probably flushing but not aspirating because it's too short, and the tip is now abutting the innominate SVC junction, so it's hitting that wall. So when they tell you a port's not working, before you do anything, get a chest X-ray, because one thing I know is you can't make a catheter longer, so best treatment for this particular port is to take it out and just place a new one properly. Some malposition is because people are placing it without imaging guidance and it just goes where it goes. Sometimes catheters will spontaneously migrate. These are fun to treat. We can reposition them with wires, or sometimes we can do crazy things. This little picture I've been showing because it kind of looks like a cool pretzel. So in this case, this is an actual IJ port that for some reason has formed this insane pretzel. There's no free end to grab. So we went up with a sheath and a pigtail and just went around a loop of that catheter and just pulled it back down into position, which is kind of fun. We'll skip over the quizzes. TPA dose. TPA has been a bit of a revolution for clogged up catheters. The dose is 2 milligrams. Pretty much all catheters will form a fibrin sheath. I'll dwell on this for a second. Here's a little cartoon. It's basically a sort of a film on the outside of the catheter. And again, they'll typically flush, but not aspirate. It's kind of cool. If you shoot a venogram on these, you'll see the contrast. Instead of flowing freely, it goes down the catheter, then back along the catheter until it can exit the side of the fibrin sheath. And if you pull one out with the fibrin sheath intact, you can see this kind of cool sort of film over the catheter. And again, TPA has been a bit of a game changer. They realized a good marketing thing when they saw it. So they make this special super low dose 2 milligram, which is called CathFlow. It works amazing. You just put it in, you let it sit for 2 hours. 75% of patients that will restore function. If you repeat it, about 90% restore function. If that doesn't work, pretty much need to change out the device. We used to strip them with snares, which is fun, but doesn't really work that well. And the snares cost as much as a new catheter. So pretty much these days, we just replace them. If you have a residual fibrin sheath living in the vein, we'll sometimes go in and break it up, in this case with a pigtail. So venous thrombosis and stenosis and occlusion, we're going to skip over. Bigger catheters, hypercoagulable states, and your access route, subclavian versus IJ, cause it. You prevent it by not doing those things. I'll show you some fun pictures. Here's a long-term patient, probably a cystic fibrosis patient, because you can see this port is really low on the chest, which is where they're often placed pediatric ports. I don't know why. Well-placed port, but over time, the SVC had occluded, which we can go in and fix. Here's another showing how we fix them. A subclavian catheter that caused an occlusion, and in this case, a bunch of collaterals, face swelling, arm swelling. You go in with a stent and you can barely tell it was there, then you can replace your device. I'm going to finish with pinch-off syndrome just because it's fun. This is usually an NOF caused by a subclavian vein catheter that's placed very centrally. So when it's in this tight space between the first rib and clavicle, it's external to the vein. It's not protected. It gets rubbed on by these bones and ultimately breaks. You prevent it by, if for some reason you're using subclavian, stick the vein laterally, or even stick the central axillary vein. It helps to have ultrasound so that when the catheter is passing through this space, it's protected by the vein. Obviously, IJ is better. And then for all of you guys that are never, ever going to do IR, you can still be heroes by recognizing the signs of what they call impending pinch off on a chest X-ray. You treat it by going and getting that catheter. So spend a minute on this. Like all things in medicine, even pinch off has different stages, from 0, meaning it's fine, to 4, where the catheter's gone flying. So this is early, but if you look at enough x-rays and take a second on every subclavian catheter, scrutinize it, you can find this and report it, and we can get the catheter out, or they can get the catheter or port out before it breaks. So here you can see, number one, you can tell this was placed very centrally because here's the beginning of the tunnel. But if you look closely, there's this little angle and this little lucency at the top of the catheter. So that's how you can be a hero. But if you don't catch it, then you can still be a hero. So here's a chest x-ray of a port. You've seen enough of them now. Here's a port. You may follow that catheter and go, that catheter seems too short. Where's the rest of it? And there it is, going from the right atrium into the right ventricle. Another NOF. These are maybe my favorite of all procedures, because they're like playing those claw games at the arcade or bowling alley, except that you actually usually get something. So we go in with our snare, our version of the claw. You can go from IJ or femoral, but this case we went femoral. You can see our snare has grabbed the top of that catheter. We pulled it down, looped it over. There's very unprofessionally my fingers, and we pull it out. So in conclusion, we love ports. In general, if you're going to be doing any kind of general radiology practice, learn venous access, love venous access. Even if you don't think you're that great, you're probably going to be the best one at it in our hospital or in your hospital. And that's all I've got. If you come to Bainbridge and walk by our house, give our goats some treats. Have just a minute or two if anybody has any questions. And otherwise, I will bid you a good sort of sunny afternoon. All right. Thanks, you guys.
Thank you.
You bet.
Thank
Have a good afternoon.
you.